Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about autoimmune diseases. When I left off last week, I was talking about autoimmune diseases with which platelets is associated with. Now, we have three cells that circulate in our circulation for different reasons. The red blood cell is there because inside the red blood cell is a substance called hemoglobin. The hemoglobin is the substance to which oxygen is attached so that it can be carried throughout the body to keep us well oxygenated. That is, frankly, the main function of the red blood cell. In addition to that, of course, it keeps us from being anemic. When it's too low, we become anemic, we get tired, weak, headachy, blah, 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 blah. And we get pale looking and so on. The next cell, of course, is a white blood cell, and I've spent quite a bit of time talking about it, and I won't bore you with that again. The third cell that circulates is a cell called platelets. Platelets are without shape. They're an odd-looking thing with no particular shape attached to them, and they're produced by a cell that's found in the bone marrow called megakaryocyte, which is also a big, ugly-looking, shapeless type cell. And what are the functions of the platelet? The main function of the platelet, frankly, is to prevent us from bleeding out. For instance, when we sustain a cut or laceration or anything of that sort, the first cell that runs toward that laceration or the cut is the platelet that becomes aggregated. The aggregation of the platelet starts the process of a clot formation. Now, my colleagues should forgive me for being so basic, but the public watch the show and they need to know the basic thing. So that's the main function of the platelet, really. There's a whole lot of other stuff that platelet can do that is, some of it is good, some of it is bad, in addition to just the aggregating to prevent us from bleeding too much. But I will not get into those details. They're very complicated, very complex. I'll let that go. So now you understand when I get stuck with a sharp knife or nail or whatever, the first thing that will run toward that puncture is the platelet, the aggregate, then begin the clot forming that then going to seal the hole. That's very important. So when the platelet is the quantitatively abnormal or qualitatively abnormal, that's a problem. Now, the condition that I'm going to talk about today called ITP, autoimmune thrombocytopenia, is a very common problem. For every million individual, 100 people have ITP in this country and across the world. Nobody knows what causes ITP, the same way nobody knows what causes other autoimmune diseases. But ITP can come by itself as an autoimmune phenomena, or it can be associated with other conditions, like I mentioned last week, such as Hashimoto's thyroiditis, celiac disease, Evans syndrome, just to name a few. And the platelet can be low when this disease come into play. And there are many, many more autoimmune diseases that can be associated with low platelet. Okay, and low platelet can result from a whole lot of other things that I'm not going to, again, bore you to. I'm going to stick particularly with the autoimmune part of it. An autoimmune phenomena is where something happened to the body and the body itself develop that something, whatever it is, becomes an antigen, and the body develops antibody as a reaction to it. And then you have the formation of an antigen-antibody complex. Those complexes, in the case of ITP, causing the platelet to be too low. The antigen-antibody complex are taking them out, particularly the spleen is this, the organ itself that's sucking them out because they're being read by a whole lot of other things as foreign substances. And it has been known for way before I was born, which is many years ago, that this plane is the culprit here that's taking them out. How does one know if one has ITP? Well, first of all, you have to understand, as I talk about this, there are other platelet-associated autoimmune diseases that has nothing to do with bleeding. The reverse. They can cause clotting, but I'm not talking about that in this segment. I'm going to specifically talk about ITP. Well, one can start bruising, nosebleed, blood in the urine, blood in the stool, excessive menstrual flow, excessive bleeding during delivery of a fetus, on and on and on and on. Okay? And of course, there's depending how low the platelet is, other than the nosebleed, the gum bleed, one actually can bleed spontaneously into the brain. And I'll tell you the number that we use. If one goes below that, then one runs the risk of spontaneous bleeding into the brain, etc. Now, of course, the way one knows that one has the possibility of having ITP, you start bruising, having a current nosebleed, I say your gum is bleeding, excessive blood loss during menstrual period, etc., blood in the urine, passing blood in the stool, then you will seek medical care. And the physician then will take a history. This is, by the way, why it is so dangerous. As important as aspirin is, as important as NSAIDs are, for one to start taking these things by oneself without the advice of a healthcare professional, i.e. a clinician. Very crucial. Let me give you an idea how crucial that is. We have a disease called Van Willebrand, which is a platelet-associated quality. This is number one qualitative platelet abnormality in the world. 70 million individuals in the world have low platelet. Van Willebrand disease. Have Van Willebrand disease. Well, Van Willebrand disease is a qualitative platelet abnormality that can cause a whole lot of bleeding to occur. I mean, a really serious medical problem. And yet, people don't know that if in this country, there's more than 3.5 million people who have Van Willebrand disease. And people go right ahead and take the aspirin because one watch TV and they're saying the aspirin is good for prevention of cardiovascular disease, which it is. Aspirin is an amazing medication. In the history of mankind, I dare to say to you, very few medication will ever outdo aspirin as a medication because it has so tremendous amount of value and can do amazing things if one knows how to use it and when to use it. But these things are being sold over the counter, and people have them not only that across the world. People have rheumatoid arthritis or osteoarthritis. It's a very common thing. The cheapest medication they have access to, believe it or not, is aspirin. In this country, we don't use aspirin to treat rheumatoid arthritis or other form of arthritis. We have NSAID all over the place. But in the developing country, aspirin is the cheapest. And all these people can have this underlying qualitative platelet abnormality, and on top of that, they're going to take aspirin. You take one single aspirin, 81 milligram, that renders your platelet qualitatively abnormal for 7 to 10 days. One single 81 milligram baby aspirin can cause that to happen. So one has to be very careful before you take these things to make sure that you talk to your physician about it so that he or she can advise you whether, in fact, it is okay for you to do so. But doing so on your own is at your own risk. Therefore, then the physician who is taking care of this patient will take a complete history, as they always do, a complete work history, family history, total. Once the history is taken, then of course the physician will carry a complete physical examination on this patient. I mean complete from head to toe, the complete physical examination, because there are several things that can be found during the physical examination that may explain why the patient is bruising all over the place. Such as, for instance, let's say the patient has a very large spleen that can be palpated. Well, that can be the reason why the patient is bruising, because of abnormality that can occur because of the spleen itself, and or let's say the liver is enlarged. Well, many conditions. Because it's not just the platelet that can cause you to bruise. You could bruise because your coagulation profile is abnormal. But that can happen because your liver. It can happen because you have spontaneous disease such as hemophilia A that can occur. Believe it or not, some 25% thereabout of hemophilia develop spontaneously during lifetime. How about that? Okay, so you have to know these things. Okay, so now you finish taking your history, blah, 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 blah. What are you going to do? Well, you're going to start ordering tests. One of the tests you're going to order, of course, is a complete blood count. One of the other tests you're going to order will be a complete chemistry profile, metabolic profile. Since you're talking about bruising, one of the tests you're going to do a proton time, a partial thromboplastin time. You're going to do those things. Why? Because if the coagulations are abnormal, the patient can also bruise. Or if it's in the hospital setting, you have to do a chest x-ray, evaluate the CAT scan, take a look to make sure the person has an infection, because as I mentioned to you last week, the most common cause of low platelet in the hospital setting happens to be infection, having nothing to do with ITP, happens to be infection. So you have to know these things. So that's why the history comes very important. Was the patient in the hospital? She just discharged a week or so ago. Well, that may still be a leftover from the fact that she was in the hospital. That's why the platelet was low, because there's an infection that was occult, that wasn't picked up. Now it's becoming more obvious, etc. So you will check the urine. Is there blood in the urine? Check the stool for occult blood. Is there blood in the stool? Those are the key points that you're going to look at. Once you do that, then your results are going to start coming back. Oh, by the way, you must also do a sedate. You must also do an ANA. Why? Because I just mentioned to you that there are other autoimmune diseases that can be associated with ITP. Well, if you have Hashimoto's thyroiditis, your sedate is going to be high. Your ANA is likely to be abnormal. If you have lupus, which can also be associated with low platelet, well, you check for lupus. You check for rheumatoid arthritis. You do rheumatoid factor. You have to be very thorough, because you got to be thinking that it may be ITP by itself, and or it may be ITP associated, let's say, by Evans syndrome. Well, if it is any one of this long list of autoimmune diseases with which the low platelet is associated, all these things will have abnormal sedate, and many of them may have abnormal ANA, and so on and so forth. Crucial that you do this stuff. If the patient also complains to you about muscle weakness, this and that, well, you do a total CPK. Because if it's a myositis and or polymyositis, the CPK is going to be, the total CPK is going to be sky high. So you've done that, you've been very thorough, and now your results start coming in. The first result that's going to raise the red flag You look at the blood count, oh, the platelet is low. The normal platelet count is 140 to about 400,000. 140,000 to 400,000 is what the total platelet count is. Well, you got yourself a low platelet, 90,000, 70,000. Then you have to explain it. Was the patient taking any medications that can cause the platelet to be low? Because there's a long list of medication as well, prescribed or non-prescribed, that can be associated with low platelet. So you review the list of medication the patient's been taking, was taken, so on and so forth. So once you have this platelet that's low, then you take a look at the hemoglobin and the hematocrit. Have these things come down as well? Because the patient may have been bleeding chronically. Now, as soon as you see the hematocrit and the hemoglobin being low, you must, by necessity, also would have ordered a reticulocyte count. The reticulocyte would have told you, would tell you what type of anemia you are dealing with. Are you dealing with an autoimmune hemolytic process that also can be associated with a low platelet because it could be coming from one of those autoimmune diseases that I mentioned, and or is the patient have some other chronic conditions that can cause the red blood cell to be low, as well as the platelet. So, as I said in the past, I'll say it to you again, the reticulocyte count is your compass. You just find yourself in the middle of the ocean. Somehow you lost your way. You don't know where east is, west is, north and south. But if you understand the meaning of the reticulocyte count, what it does for you, it will set you up. It will tell you exactly which path to follow to get to where you want to go. Because if the reticulocyte count is normal and the patient is anemic, that's a normal bleeding situation. The patient is not hemolyzing. On the other hand, if the reticulocyte count is very low, well, that's a very bad situation. You're not making enough platelets. You're not making enough red blood cell. That's a hypoplastic situation. If the reticulocyte count is very high, that's hyper. That's when the patient is hemolyzing, and the body is trying to make new red blood cell by dumping a lot of baby red blood cell into the circulation. Those are reticulocytes. So this way, you don't have to be spending tons of money running all over the place, wasting time, because if you, then you're confused. You don't know what's going on. It's always a good idea in a setting like that also to do a direct Coombs test. Because the direct Coombs test will be positive, and if it is an autoimmune hemolytic anemia phenomenon that's in interplay with the low platelet, etc. See, like I said many times, I'll say it again. For every lock that exists, there's a key. Whether you're going to open the lock mechanically with the old-fashioned way, or you're going to find those fancy ways with your cell phone or what. But for every lock, there's a key. So therefore, as you practice medicine, me 47 years now, and all I do all day long is medicine. Either I'm reading it, I'm writing it, I'm teaching it, or I'm practicing it. This is what I do 24/7. I don't do anything. I don't have any other hobby. My only hobby, believe it or not, my only hobby is to write big books. That's my hobby. I turn it into a hobby. It's not a money-making thing. In fact, it costs me money. This particular book, 131 chapters, cost me several $1,000s to produce the book. And most of it, I give the copies away to colleagues and so on and so forth. Because that's my hobby. I'm not doing it for money. I could. Half a dozen calls come to my office per week. People who does that kind of stuff for a living, begging me literally to let them get involved in representing me, selling book. I'm not interested in that. So now that your platelet count is low, uh-huh, you rule out everything else that can be possibly associated with low platelet. Then you begin to narrow it down to it could be ITP. You rule out everything else. There's all the different hundreds of different possibilities. You rule that out. There's also another thing that can occur, something called petechiae. Petechiae, a little bump-like thing that occurs on the body. They're reddish and the little pinpointed stuff. They're all over the place. You see that also when you have ITP, petechiae. Okay? So now that's been done. In the past, not now, but in the past, you would wind up doing, obviously, a bone marrow and so on and so forth. Now, it's perfectly okay to go into a CAT scan, ultrasound, because you're looking to see if the spleen is enlarged or if the liver is enlarged and so on and so forth. To rule these things out, you also want to make sure that you get yourself an LDH, because sometimes the patient low platelet may be associated with an occult type lymphoma that is brewing. But if that's the case, the LDH will rule that out for you, because you cannot have a lymphoproliferative disease with a normal LDH. We say, well, how come? Well, because all those cells that can cause the lymphoproliferative diseases, all of them grow via an anaerobic pathway. Anaerobic means that they're growing without oxygen. And the end product of the anaerobic pathway, my friend, is lactic dehydrogenase, which is LDH. That's where the LDH kicked in. You can't be hemolyzing without having a high LDH. See, I'm talking about the keys, okay? So the LDH, if your LDH is normal, then that rules out several dozen possible diseases right there and then. Right there and then. But if your LDH is high, it brings in several other possibilities that you could narrow down and then make your diagnosis. Now, once you establish that diagnosis, then you start a treatment. Believe it or not, you use the LDH as well to monitor how well you are doing for the patient, how well the patient is doing. As the patient is doing better, the LDH level goes down, okay? Because you're killing the cells that are producing the LDH. If you're treating somebody for an autoimmune hemolytic anemia, besides doing the reticulocyte count, one of the best tests you have to do is the LDH. Because as the hemolytic anemia process improves, patient is getting better, so the level of LDH get better, the level of the reticulocyte get better as well. So you use them not only to diagnose things, you also use them to monitor the action of the disease as it's responding to your treatment. So those are incredible things that you have to remember. So now let's say, for instance, you did all this stuff, some of them fancy, some not so fancy, to rule out everything else that can cause your patient to have low platelet, and now you narrow it down to ITP. Aha. Immune thrombocytopenia. So what do? Well, here's the deal. You don't run right away and start treating the ITP. You run right away, start treating it if the patient is at risk for spontaneous bleeding. If your patient is having a lot of bleeding problem, and I mentioned all of them, nosebleed, gum bleed, bleeding all over the place, petechiae all over the place, heavy menstrual. Those are all indicators that your patient is going to need to be treated, because this is a patient that is actively in trouble. Then you're going to have to come up with how you deal with this. Well, The most common treatment that existed in the past happens to be steroid. And I'll take a moment here and give credit where credit is due. This fascinating medication, I just ordered it earlier before I come here for a patient that I'm treating in the hospital, was invented and created by a Negro gentleman. That's right. A Negro gentleman who actually went to school here in America, went as far as getting a master's degree, but he wanted to do a PhD. Because he was Negro, they refused to accept him here to do a PhD. So he was forced to go to Scotland, Edinburgh, I think it was, in Scotland, to do his PhD. And this gentleman came back here, did a whole bunch of stuff. A whole bunch of stuff. At one time had, I think, 2 or 3 active laboratories. Upjohn Laboratory, Smith Klein, those are all his laboratories. Was in Wall Street, became a multimillionaire. But one of the medications that he actually created happened to be corticosteroid. That's right. He invented corticosteroid, and corticosteroid, as we speak right now, I dare say, beside penicillin, is probably the most commonly used medication across the world. You can't practice ophthalmology without steroid. Dr. Percy Julian is a gentleman that invented steroid. You can't practice pulmonary medicine without the use of steroid. You can't practice rheumatology without using steroid every day. I can go on and on and on. You can't practice hematology as well, or oncology, without steroid, because we use steroid every day when we putting patients on chemotherapy, or as a hematologist, we use steroid just to treat different hematological problems as well. It was Percy Julian, a Southerner, a black gentleman. Now we call them black, Negro. He was refused admission in PhD program in this country and had to go away, Scotland, to get his PhD. And the story of steroid, many more things that Dr. Percy Julian did, including the stuff that's in your fire, when that foam you see in your fire to put fire in your house. He did that. Listen, I'm going to stop here. I'm going to continue this discussion next week. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.